Good morning, everyone. As we are already into the festive seasons, I wish you everybody a very happy Diwali. Respected Emeritus Chairperson Dr. M.L. Swarnkar sir, Pro VC sir Dr. Kapoor sir, Dr. Malhotra sir, Dr. Jaiswal sir, other senior faculty members, colleagues and dear students. The Department of Orthopaedics is presenting today's CCR, and the topic is a 74-year-old lady with painful right shoulder. Our second year residents Dr. Nakul Fauzder and Dr. Rishabh Saxena would be presenting the case. So I'll request Dr. Nakul Fauzder to come up on the dais and start presenting the case. Yes, sir. So we have trauma equipments already with us. We have scopy instruments available with us. We have arthroplasty sets available with us, and we of course have the C-arm image facilities. We have 2 equipped operation theaters. So that is all we have. Special clinics we are running: clubfoot clinic, foot clinic, arthroplasty clinic, arthroscopy clinic, spine clinic. That's what we are running.
Good morning, esteemed senior professors, faculty members, my seniors and colleagues. I, Dr. Nakul Fauzder, second year resident from Department of Orthopaedics, is presenting a case of 74-year-old lady with painful shoulder. Coming to the case, we had a 74-year female homemaker from Jaipur came to orthopedic OPD with chief complaint of pain in right shoulder since 6 months, reduced range of motion and limitation of activities of daily living since 3 months. The patient was apparently all right 6 months back when she sustained a trivial fall at home. Then she complained of pain which was sudden in onset following trauma. It was gradually progressive in severity. It was dull aching and intermittent in nature. It was radiating to neck and right arm and often increased at night. The pain aggravated on daily routine activities and got relieved with rest and medication. The pain was associated with restriction of motion. Initially, she didn't feel any restriction in her right shoulder, but as the time passed over the next 3 months, she experienced difficulty in certain movements like forward elevation, like doing side elevation, and in reaching back. Due to limitation of activities of daily living, she had difficulty in performing her routine activities like combing hair when she tried to bring her hands upwards, like in dressing and undressing, and in reaching over objects like working in kitchen. There was no history of fever, weight loss, loss of appetite, any tingling or numbness in fingers, and there was no multiple joint pain or morning stiffness. There was no history of diabetes mellitus, hypertension, epilepsy, or any thyroid disorder. She is vegetarian by diet. Her bowel and bladder habits are normal and regular. She took adequate sleep of 6 to 8 hours. There is no history of alcohol intake, smoking, or any substance abuse. She attained menarche at the age of 14 years and menopause at 55 years. She has 2 male and 1 female child. There was no complaint of similar joint pain in her family members, and the family history was non-contributory. Now, based on the history, I would like to ask the audience what could be the possibilities she might be suffering from. Yes? Yes, osteoarthritis can be present. Looking at her age and joint stiffness, osteoarthritis. Any other?
I think it is started with the fall injury. So first diagnosis has to come from the injury of some ligament or joint or
any traumatic
like
possibility?
Yes.
So looking at the clinical picture of the patient, because of a chronic history and gradually progressive pain, most likely it's look like a degenerative issue. Also, as she sustained a history of trauma, she might sustain some traumatic injury. Again, looking at her age and chronic history, there might be an inflammatory cause also. Infective cause is less likely, like septic arthritis and tuberculosis. Other metabolic and miscellaneous causes could also not be ruled out.
What are the structure involved in making of the rotator cuff?
Rotator cuff, yes. It comprises of mainly 4 muscles, sir, which comprise of rotator cuff. The subscapularis, supraspinatus, infraspinatus, and teres minor.
The most important muscle which is usually get injured when the rotator cuff injury takes.
So mostly supraspinatus is injured, sir, because of that crowd value. Now coming to general physical examination, patient was conscious, cooperative and well oriented to time, place and person. Her BMI is 23.9 and her vitals were within normal range. She was afebrile. Before coming to inspection, I would like to mention that the images represented are here just for reference purpose, and these are not her actual patient. In orthopedic, coming for inspection from front, both shoulders were at equal level and the shoulder contour was maintained, and both nipples were also aligned equally. From side, the curvature of spine was normal and the head was well centralized. There was no scar, sinus or dilated veins present. From back, both scapulas were aligned normally. There was muscle wasting in supraspinous and infraspinous fossa, and the cervical and dorsolumbar spine was normal. In palpation, the inspectory finding of the muscle wasting in supraspinous and infraspinous fossa was confirmed on palpation. There was no local rise in temperature and no crepitus on movement of shoulder joint. Mild tenderness was present over the bicipital groove, and no other soft tissue or bony tenderness was elicited. In orthopedic examination, movements and measurements have significant importance. These are the patient's images. She has an active forward flexion of 0 to 30 degree, which passively goes up to 140 degree, which is normally up to 180 degrees. Her extension was restricted to 30 degrees, both active and passively, which is normally up to 60 degrees. Her abduction was actively restricted to 50 degrees and passively extending up to 120 degrees. Her adduction was minimally restricted to 45 degrees, both active and passively. The internal rotation was also restricted. Actively it was 20 degree and passively it was up to 40 degrees. Her internal rotation was limited as her thumb could not go up beyond the buttocks, which normally reaches up to inferior angle of scapula or D6, D7 spinous process. For power assessment, we use...
Sorry, you have mentioned that the passive range of movement was more than the active range.
Yes, sir.
What should you also not mention whether the passive movement induces pain? Does it cause pain?
Yes, sir. No, sir, because passive movement...
Yes or no? You said both. Because I would presume that if there is some inflammation going on in the joint, then passive movement beyond what she is on her own doing will cause pain.
Yes, sir.
Whereas if it is because of muscle atrophy, then passive movement should not cause pain. Am I correct?
Yes, sir. For power assessment, we used universally accepted Medical Research Council grading. The muscles responsible for forward flexion, backward extension and adduction has full power of 5 by 5. So it is very important to test for rotator cuff muscles. There are 4 rotator cuff muscles. From anterior to posterior, they are subscapularis, supraspinatus, infraspinatus and teres minor. The rotator cuff helps in providing stability to the shoulder joint and helps in movement. We tested for individual muscle power. The supraspinatus power was 2 by 5 as tested by full Kent test. The infraspinatus power was 3 by 5, which is correlating with the inspectory and full Kent test, sir. Full Kent test, sir. Empty can is also there. No, sir. It is a test like when we hold a can, the thumb is facing upwards, so the alum muscle is responsible. The infraspinatus power was 3 by 5, which is correlating with the inspectory and palpatory findings of muscle wasting in supraspinous and infraspinous fossa. The subscapularis also appeared weak, where she got 4 by 5 power in, as confirmed by belly press test and bear hug test. She has good teres minor power as tested by external rotation test against resistance, which was 5/5. Now coming to measurements, her arm length was equal on both sides, that is 62 centimeter, and mid arm circumference was 24 centimeter on both sides.
See, this is a teaching exercise also, so you have to teach everyone.
Yes, sir.
You have to presume that everyone doesn't know. From where to where is the arm?
So the arm is measured from the acromion process to the olecranon process, sir.
So you have to
and the midpoint is taken as the mid arm circumference.
And my request to all departments which are going to present CCRs in future, because we know when our turn is going to come, whenever possible, whenever required, please make short video clips. For example, all these range of movements.
Yes, sir, we have added videos for that, sir. Yes, sir. Any examination of extremity is not complete without neurovascular assessment. So, our patient in the distal pulsations were normal in both upper and lower limbs, and this is an general outline of anterior and posterior dermatomes. And our patient had no sensory loss or paresthesia in both her upper limb and lower limbs. We also tested for. We also examined her cervical spine, and she got full painless range of motion in all her cervical spine movements. Her other joints were also examined, such as elbow, wrist, hip, knee and ankle and spine, and no significant abnormality was found.
Most important is the left shoulder.
Yes,
the contralateral shoulder. What was the active range of movement in that shoulder? Because suppose that shoulder also the range of movement is same as the diseased one, then probably it's age or something which is affecting. Whereas if there is a gross difference, then whether the trauma played an important role, that would become important.
Yes, sir.
So in any organ which is left and right, the best is to compare with the normal.
Normal side. Yes, sir. Yes, sir. In video, showing doing movement on both sides, sir. The systemic examination, her higher mental functions and all cranial nerves were normal. S1, S2 was heard and there were no murmurs. Bilateral air entry was present and her abdomen was soft and non-tender to touch. To summarize, we have a 74-year female with right painful shoulder since 6 months, and the pain was sudden in onset and gradually progressive following the trauma. There was muscle wasting in supraspinous and infraspinous fossa and mild tenderness over the bicipital groove. There was pain and restricted range of motion while abducting and externally rotating the arm, and there was reduced supraspinatus and infraspinatus power. To conclude our diagnosis, we investigated the patient.
No. What is your clinical diagnosis before you investigate?
Sir, any muscular pathology, cuff pathology, sir, because movements were also restricted and painful. Passive movements were possible, so the joint is less affected. The soft tissue is affected mostly, sir.
So is it traumatic?
Yes, sir, likely traumatic. Sir.
So traumatic rotator cuff injury, right?
With the rotator cuff, sir. Yes, sir. Yes, sir. Yes, sir.
Somebody is suggesting that some inflammation has taken over the
Sir, actually there was injury, so the use that it was restricted, which resulted in that developmental pathology of both the joints, sir. To conclude our diagnosis, we investigated the patient and requested for blood investigation and radiological imagings like X-ray and MRI. In blood investigations, we didn't find any infective, inflammatory or metabolic cause of her symptoms.
What is anti-CCP?
Sir, anticyclic cetylated peptide. Yes, sir. In inflammatory cause, sir, it is important investigation to rule out autoimmune.
People using
Autoimmune and autoimmune disease, sir. Yes, sir. Anti-CCP and RA factor is specific for rheumatoid arthritis. Yes, sir. Now I would like to request Dr. Aakansha Agarwal ma'am to present the radiological investigations.
Thank you, Nakul. A very good morning. I'm Dr. Aakansha Agarwal Chandra, Assistant Professor in the Department of Radiology. I'll be talking about the radiological findings in this patient. So for any patient who presents with shoulder pain, the first radiological investigation that we do is a radiograph.
Head of the radiology is here. Why not residents? Why assistant professor is presenting? Oh. Okay. That's fine. Okay. Because encouragement for the residents. Thank you.
So we have a true anteroposterior radiograph for the Grashey's view for this patient. On this radiograph, we can see the glenohumeral joint here. There is sclerosis in the inferior aspect of the subchondral sclerosis in the inferior aspect of the glenohumeral joint with cystic change. In addition to this, there is an important parameter that we have to look for, which is an acromiohumeral interval. It is the space between the acromion and the humerus. The normal range is 7 millimeters. In this patient, this distance measured 5.5 millimeters. Apart from this, there is no other obvious bony pathology. There is mild acromioclavicular joint arthropathy evident on a radiograph. The rest of the visualized bones are normal. The soft tissues are normal, coming from center outwards. The trachea is central. There is no obvious mass in the visualized neck. The supraclavicular fat is preserved. The deltoid projection is also normal. The visualized right lung field is normal. So we have a classification known as the Hamada classification with Walsh modification, which is used to characterize and categorize glenohumeral arthritis. So with this patient, we have arthritis of the glenohumeral joint with mild reduction of the acromiohumeral interval. As per this classification, our patient falls in the grade 4A of Hamada classification, which means glenohumeral arthritis without acetabolization. So now once we have this, we have a suspicion of an underlying inflammatory rotator cuff pathology, to evaluate which this patient underwent an MRI. So these are fat-saturated multiplanar images of the MRI of the right shoulder joint. This is an axial image which shows that there is a complete tear of the subscapularis muscle. In addition to the complete tear, we can also see that the tendon quality is very poor. The tendon is retracted up to the level of the glenohumeral joint. On the coronal images, we can see the supraspinatus tendon is also completely torn. It is also of a very poor quality and retracted up to the glenohumeral joint. In addition to this, we can see this is the cartilage over here of the glenoid cartilage, and the fluid from the joint is extending deep to the cartilage. This means that the cartilage has come off the bone, and there is subchondral edema with cystic change, signifying severe glenohumeral chondromalacia. In addition to this, on this coronal image, we can also see that the humerus is slightly elevated or superiorly migrated, corroborating with our findings of a reduced acromiohumeral interval on X-ray. On the sagittal image, we can see that the infraspinatus tendon is also torn and retracted up to the level of the myotendinous junction. There is severe acromioclavicular joint arthropathy.
So I wish you had shown corresponding normal images also. Like MRIs is difficult to comprehend for quite a lot of us.
Yes, sir. So whenever we assess any patient with a rotator cuff tear, we have to look at the muscle belly of that particular tendon, because that helps the surgeon to decide the operative intervention. For this purpose, we have another classification called the Gutelier classification, which helps us to identify the degree of atrophy that has taken place in any muscle. So for our patient, arrow is not working here. Yeah. So for our patient, for supraspinatus muscle, the patient falls into a grade 3 category of muscle atrophy, because we have as much fat in the as much as muscle fibers within the muscle belly. For subscapularis or infraspinatus, the patient falls into a grade 4 category, where fat is more than the muscle fibers. So we have a grade 3 and grade 4 atrophy of the muscle bellies of this patient. So on radiology, the final diagnosis is a massive rotator cuff tear with severe glenohumeral chondromalacia, suggestive of rotator cuff arthropathy, Hamada grade 4A on radiograph, with Gutelier grade 3 and 4 atrophy of the muscle bellies, associated severe acromioclavicular joint arthropathy.
Thank you, ma'am, for enlightening the radiological aspects of X-ray and MRI. On the basis of history, examination and imaging findings, these are we have ruled out some miscellaneous inflammatory, metabolic, infective and traumatic causes. And on the basis of history, examination, imaging findings, I would like to conclude my final diagnosis as right shoulder rotator cuff arthropathy, Hamada grade 4A. Now I would like to invite Dr. Rishabh Saxena to discuss the management of our patient.
Thank you, Dr. Nakul. Good morning, respected dignitaries, senior faculty members and my colleagues. I am Dr. Rishabh Saxena, second year resident from the Department of Orthopaedics, and is here to discuss the management of rotator cuff arthropathy. So on completing the workup and reaching a diagnosis of rotator cuff arthropathy, we explained the patient that it is a shoulder degenerative joint disease resulting from a rotator cuff tear leading to abnormal glenohumeral articular surface damage and subsequent leading to migration of the humeral head. So this animated video shows the pathogenesis of rotator cuff arthropathy. As we can see, in normal rotator cuff and abduction, the rotator cuff pushes the head downwards and keep it centered against the glenoid fossa, thus making the abduction possible. When it is torn, the head migrates superiorly and this leads to failure in abduction. On repeated movement, as we can see in the video, the articular surface is damaged, which finally leads to rotator cuff arthropathy. So for our patient, we initially started with conservative treatment. We gave, which was rehabilitation for 6 weeks, which also worked as prehab in our case for the surgery. If this fails, we give intra-articular injection with steroid along with rehabilitation, for which a patient opted out due to its short-term benefits. So we were left with the final option of
Rehabilitation, which physiotherapy exercise?
Yes, sir.
What you do?
Yes, sir. For the conservative treatment, we give analgesics, anti-inflammatory along with vitamin D3 and calcium. And the physiotherapy for this particular thing, we give rotator cuff and scapular strengthening exercises along with shoulder shrugs and anterior capsular stretches, sir. The aim for a surgery is to restore the function of the shoulder joint, to provide pain-free activity for the patient and to improve quality of life. Since we have discussed earlier that the articular surface of the joint is completely damaged, therefore the only option is to replace the joint. We have 3 modalities. The first one is shoulder hemiarthroplasty, then total shoulder arthroplasty, and the reverse total shoulder arthroplasty. Discussing the pros and cons of each modality. First, shoulder hemiarthroplasty. As the term hemi in the name, it suggests that we change only one component of the ball and socket joint, that is the humeral head with a new implant. So the main indication for this modality is that the humeral joint surface is damaged, but the glenoid surface is normal. The total shoulder arthroplasty, in this modality we change both the components of the ball and socket joint, that is the humeral head and the glenoid cup. It is indicated in a patient with glenohumeral arthritis, but the patient should have a functioning rotator cuff. So the prerequisite for hemiarthroplasty and the total shoulder is that the patient should have an intact rotator cuff, as its function is to depress the humeral head downwards and keep it centered against the glenoid fossa, thus making the abduction possible. Since we have discussed that the rotator cuff is irreparable in a patient, so these 2 modalities did not fit our patient's profile. The patient should also have an adequate deltoid power, which is required for abduction.
At the same time, the rotator cuff cannot be repaired? That you replace the joint as well as repair the cuff?
Sir, if the patient would have come earlier, so when she had a history of fall, so we are assuming that she suffered from rotator cuff tear then. If she would have come that time, we might have repaired the rotator cuff. Sorry, sir?
If she had reported to you earlier and you had diagnosed the rotator cuff
Yes, sir.
injury earlier in the course of
Yes.
the disease, would she still require like a shoulder joint
Sir,
replacement?
actually, sir, as beautifully mentioned by Dr. Aakansha ma'am, that as for now, the rotator cuff is severely retracted and the muscle has atrophied. Looking back, if the atrophy was not started or the cuff is not retracted severely, we would have repaired the cuff and the mobility would have restored, sir. The third modality is reverse shoulder arthroplasty. As in this comparative picture, the picture on the right shows that we are replacing the humeral head with the cup and the glenoid cup with the ball implant. So therefore we are reversing the anatomy of the joint. Hence it is known as reverse shoulder arthroplasty or non-anatomical joint replacement.
Why do it?
Yes, sir. So the main advantage for doing this surgery is that it medializes the center of rotation. To understand this, The picture on the right, the left image shows the native shoulder joint, in which this center of rotation, marked with G, is at the center of the head of the humerus. So, on doing the reverse shoulder arthroplasty, the center of rotation is migrating towards the base of the glenoid. Sir, yes, sir. Sir, this one. So, the increased lever arm for the deltoid gives it advantage for abduction. So, it is basically taking over the function of the rotator cuff, which is lacking in our patient. The other advantage is this, the implant for this is inherently more stable, which prevents the proximal migration of humerus. And the most important point is that it is independent of rotator cuff integrity, thus making it the only option for a patient. So the main indication for reverse shoulder arthroplasty is painful cuff tear arthropathy. Moving forward, I would like to invite Dr. Harsimaran to discuss the anesthesia.
Good morning, respected dignitaries. I am Dr. Harsimaran, second year postgraduate resident from the Department of Anesthesiology, and I will be continuing with the anesthetic management of reverse shoulder arthroplasty. The anesthetic concerns were well anticipated before the surgery itself, keeping in mind the first is the age of the patient, which makes the patient more fragile for the cardiovascular and the neurological compromises in the perioperative period. Second one being the B chair or the sitting position for the surgery. This position is different from the usual supine position where heart and brain lies in the same plane and will be discussed further. And third one is planning of the post-operative analgesia, keeping in mind again the age group of the patient, so that we can spare the patient from the side effects of known post-op analgesics like opioids. Now the B chair or the sitting position, as we can see here, the heart and the brain in the usual surgeries where the patient is in supine position are at same level. Here the back is inclined up to 60 degrees and the brain is above the level of the heart, which has its own physiological implications. Like every organ has its own autoregulation. Similarly, the brain has its cerebral autoregulation, which are lost when we give general anesthesia to the patient. So here the cerebral perfusion is completely dependent upon the systemic mean arterial pressures. For every 1 centimeter elevation above the level of the heart, there is a drop of 0.75 mm of mercury's mean arterial pressure. Roughly, there is a gap of 20 centimeter between heart and the brain in this position. So multiplying, we get an average difference of 15 mm of Hg drop of cerebral mean arterial pressure in this position. So we are okay with it because the brain can perfuse at a pressure of 50 millimeters of mercury. So throughout the surgery, our aim would be to keep minimum the mean arterial pressure, systemic mean arterial pressure above 65 mm of Hg. So the physiological effects are decreased cerebral perfusion, as we can see because of the gravity also, and because of CVS there is venous pooling in lower extremities causing decreased preload, decreased stroke volume following the decreased cardiac output, following the decreased mean arterial pressures and decrease in the cerebral perfusion pressures. Now the potential complications would be because of excessive neck flexion, there can be vascular obstruction in the neck, kinking or obstruction of the endotracheal tube, tongue or oropharyngeal airway swelling. Pressure injuries include injuries of the ischial tuberosity, nerve damages to the brachial plexus, to the ulnar nerve and the sciatic nerve. Venous air embolism is a known entity. Ischemic brain injury, stroke and neurocognitive dysfunction can also take place in this particular position. The PAC for this pre-anesthesia checkup was done 1 week prior to the surgery. Patient was labeled ASA, that is American Society of Anesthesiology grade 1, which makes it a low risk patient for the surgery. The comorbidities were nil. The metabolic equivalent score was more than 4. Patient was hemodynamically stable and the pre-operative investigations were within the normal limits. The plan of anesthesia.
Go back to the
yes,
previous.
sir.
Whenever you show any image related to a patient, the identity has to be masked.
Sure, sir.
Except when you are doing a departmental audit presentation where it is important to know which patient it was. But
Yes,
in a
sir.
public forum, everywhere identity has to be masked.
I'll keep it in mind, sir. The anesthesia management now. The patient was planned for general anesthesia with right-sided brachial plexus block. The patient was he kept hemodynamically stable throughout the induction. The sympathetic stress response was obtended. We used a flexometallic curved oral endotracheal tube to prevent kinking. Maintenance of anesthesia with inhalational anesthetics and muscle relaxants was done. Patient was taken on controlled mechanical ventilation with volume control mode. Use of rapidly eliminating drugs was preferred, keeping in mind the patient's age group. Mean arterial pressure was kept above 65 millimeters of mercury, as explained before. Adequate padding over the bony prominences and the pressure-prone areas was done. Now, for the intraoperative and post-operative analgesia, we had given patient right-sided brachial plexus block. There are several approaches to this block. We had chosen the interscalene approach. Here, the drug is deposited between the anterior scalene and middle scalene muscle. Here, we are able to block the C5, C6 and C7 nerve roots of the brachial plexus, which are responsible for the nerve supply of the shoulder joint. It was an ultrasound-guided USG block. We had given bupivacaine and lignocaine with adjuvants like dexamethasone, which prolongs the action. This decreased our intraoperative requirement of the analgesics, maintains the stable hemodynamics of the patient, and provided this one single injection provided a post-operative analgesia of up to 18 hours. The patient was managed with balanced salt solutions intraoperatively. The blood losses were covered with the same, and the total duration of surgery was 3 hours. We were able to extubate the patient on the table without compromising with the cardiovascular and the neurological functions of the patient, keeping in mind that the patient was an old age patient with a unusual position, surgical position. Thank you. Now I would like to call Dr. Rishabh for further continuing the surgical part.
Thank you, Dr. Harsimaran. So taking it further, the most important step is the patient position. As discussed, this is the beach chair position and the cephalic and the caudal end of a patient with the arm draped freely. For reverse shoulder arthroplasty, we do it via deltopectoral approach between the two major muscles of deltoid and pectoralis major. This is the animated video. It shows the surgical steps for reverse shoulder arthroplasty. After dislocating the joint, we can see that the glenoid and humeral articular surfaces are damaged. First, we put the proximal humeral zig and cut the damaged head at the anatomical neck, and then we cover it with a protector plate. Then we expose the glenoid 360 degree and we apply a glenoid base plate and we fix it with stabilizing screws. Then we peripherally ream the glenoid and we mount a trial head implant over the glenoid. This is not the final implant, this is the trial implant to assess the size of the final implants. Moving on to preparing. Okay, so these are the clinical pictures of a patient. As we can see that we are making an incision in the deltopectoral groove between the pectoralis major and the deltoid muscle. After doing the dissection and dislocating the joint, we expose the humerus and we can see that the humeral head is severely damaged with osteophytes. We then apply the proximal zig at the humerus as shown in the video, and we cut the humeral head at the anatomical neck with a bone saw. The next step is to expose the glenoid circumferentially and put a guide pin. Then the next step is to mount the base plate as shown in the video with the stabilizing screws. After that, we mount the glenosphere or the head implant over the glenoid. Then moving towards glenoid, we put the humeral stem implant, and after putting the final implants, we reduce the joint. And it is a protocol to check the intraoperative stability by doing maneuvers such as internal external rotation and abduction. After being satisfied with the joint stability, the most crucial step is to assess the soft tissue tension of two major muscles, which is the coracobrachialis and the deltoid muscle. It should neither be too tight or too loose. This is the immediate post-op X-ray of a patient, and we can see that the implants are well placed in the center. This is the 14-month follow-up X-ray of a patient. There is no signs of implant loosening or lysis. As we can see in the pre-op video of a patient, her forward flexion of right shoulder was up to 30 degree, whereas normal on the left side. Her abduction on the right was up to 50 degree and normal on the left side. On internal rotating the arm, her hand was reaching the buttocks and she was unable to touch her head. But as we can see in the video, she was able to passively achieve movements, thus making it a primary rotator cuff insufficiency. This is the 14 months follow-up video of a patient. As we can see that she has achieved active full forward flexion movement of right side. She also got full abduction in the right shoulder, which was preoperatively severely compromised. On asking her to do external rotation, which was comparable to the left side, and the power was also good post-operatively. The internal rotation of a patient was normal. As we can see, she was able to reach up to the lower thoracic spine. So now I would like to invite Dr. Rohit Goyal sir to take the discussion further.
Thank you, Dr. Rishabh. Good morning to all dignitaries, senior teachers, my colleagues and seniors. So, as we have concluded for the today's case that we had a 74-year-old female came to in our OPD with following a trivial trauma. She had shoulder pain which progressed with the time, and we concluded a diagnosis with the help of radiological support to rotator cuff arthropathy, Hamada grade 4A. And we performed a reverse shoulder arthroplasty which gives gratifying results if you do it properly and with a sincere rehab. So there is a contribution of patient equally as a surgeon. Regarding the reverse shoulder arthroplasty, it was first described by Bido and Alloy in 1970, but their biomechanical design was not adequate, so they had a very high failure rate. Then the Gremont come in 1981 with the concept of medialization, as explained by Dr. Rishabh. Regarding the numbers, the USA directory has shown that there is a significant increase in numbers of reverse shoulder arthroplasty, which was up to 23,000 in 2011 to 63,000 in 2017. A systematic review from 2005 to 20 has also noted that the complication rate for reverse shoulders have been significantly reduced to 9.4%, which was 24% previously, and the revision rates of these surgeries have been reduced to 2.6% only, which was 10% initially. Recent data also suggested, which is contradictory to the previous data, that reverse shoulder, even if patient have some loss of function, but their satisfaction rate is very high, and the likelihood of implant failure and the revision surgery is very less compared to those over 65 years of age. So to take home today, the prevalence of cuff tear has been seen to be increasing with the age. That is just 10% in patients less than 50 years of age, up to 28% in patients more than 70 years of age. So as sir has mentioned, it's been discussed previously that the cuff tear should be managed initially, because we can repair it by arthroscopically or by open means. When the patient landed to such situation, when the cuff is irreparable, then and the patient has started to develop arthritic changes, then the only option which you are left is the reverse shoulder arthroplasty, because that is the only solution to give you a pain-free mobile joint. It helps us to give excellent outcomes. I would like to thank the management, our Department of Orthopaedics, to give me an opportunity to work for complex shoulder surgeries. We have done reverse up to 7 numbers in our department. We have done HAMIs up to 20. We have done around 12 cases for locked posterior dislocation, which is a rare entity, and we'll publish it soon. It's the world's largest series. We have done shoulder instability work both arthroscopically as well as open. Rotator cuff tears are routinely done by all of us. And we also doing complex traumas like scapular fractures and other complex proximal trauma surgeries. Actually, these are the videos of our patient operated in Mahatma Gandhi for shoulder instability, sir. So on the behalf of Department of Orthopaedics, I would like to take this opportunity to thank and express my deep regards for all the collaborating departments, especially the radiology and the anesthesia department. Our sincere regards and thanks to the CCR reviewing committee and the management of Mahatma Gandhi University of Medical Sciences and Technology. Thank you, sir.